the AI infrastructure, which is not doubling every 2 years, but is actually doubling or even tripling every year.
An AI agent that looks like Dr. Dragutsky, talks like Dr. Dragutsky, and can actually diagnose GERD in this particular conversation almost as well as Dr. Dragutsky. The difference is, can you do that 10,000 times and be as accurate as Dr. Dragutsky every single time?
We haven't yet, as the world, arrived at AGI, artificial general intelligence. It is going to far surpass its own intelligence just a short while from now.
Maybe a whole bunch of AIs will sit together and say, hey, why don't we just go ahead of the humans and decide to solve problems they're not even seeing?
It's going to create more diverse revenue streams for GI and just the healthcare space that we haven't even thought of.
This is scope forward, not just scope forward.
Are you a robot?
Welcome everyone to the Scope Forward show, and thank you all for joining. For those in the audience, this conversation involves NextServices. It's a company that I co-own along with Satish, and it also involves our partner 100MS and then 1GI, which is a client. I'm calling this out because it is relevant to our discussion. It sets the context. The reason I want to host this conversation is very simple. I've been close to this work from the very beginning, how it started, how decisions were made, and what it actually took to move from idea to execution. Today, I want to break that down openly and practically, how a real scaled GI platform approaches AI transformation, not as a tech experiment, but as a leadership and operating model shift. To my knowledge, this is the first time in the GI industry we're having such a conversation so directly. My hope is that by the end of it, leaders listening or watching won't just be inspired, but will have a much clearer sense of what it actually takes. So with that context, I want to introduce our guests today. I'll start with Dr. Michael Dragutsky, chairman of 1GI. And Mike, you're a repeat offender of the Scope Forward show. This is your third time, so warm welcome again. Christa Newton, CEO of 1GI. Aniket Behera, you're the co-founder and chief operating officer of 100MS. And my partner in crime, Satish Malnaik, co-founder at NextServices, and he's also the CEO of NextServices. I'm so glad all of you are here today and we're having this conversation. So very, very warm welcome. So I want to start by asking you about each of these companies that we are representing. So Christa, I'll start with you. What is 1GI? Please set us the context with respect to what 1GI is.
Thank you for having me today. So 1GI is a gastroenterology platform. We're based in Nashville. We partner with physician groups across the Southeast and Midwest. Today, we support practices, in states like Tennessee, Ohio, Virginia, Kentucky, Indiana, Mississippi, and we're growing that footprint. So our role really is to share the infrastructure around operations, revenue cycle, data, technology, and really all of this while keeping the physicians clinically independent. A big focus for us right now, as we're going to talk about today, is AI for a lot of different reasons, but that's who we are as a company.
Thank you. And Satish?
Well, thank you again here. This is going to be a very interesting conversation, so I'm looking forward to it. NextServices, we started over like 2 decades ago, as a healthcare services company primarily, and we were mostly embedded inside GI operations, and that's the relevancy here in our participation in the conversation, primarily focusing on, revenue cycle, administrative workflows, and this was a paper-based world. And from there, over time, we have, as a company, morphed along with the industry through digitization of records, and then we've started getting into automations, operational efficiencies, etc. And now, Christa just said, we're sort of sitting at the cusp of the transformation that AI is bringing, and how the very operations and administrative workflows that we used to work with and help GI practices handle is going to be completely modified or remodeled beyond just digitization.
And Aniket?
Thanks for having me here, Praveen. I'm the COO and co-founder of 100MS. We are a technology company that builds AI agents for complex specialty patient access workflows. So everything from reading intake documents, including faxes, making patient calls, creating chart notes. We've been doing this for the past couple of years. It's a bunch of engineers from Meta, Disney Plus, Google. Excited to be here and talk about some of the work that we've done here.
Mike, I want to start with you. Our conversations about AI possibly go back to the GI mastermind. You were in the first cohort. It was the COVID period, or probably even before. So I want you to take a moment and reflect on that period and your thinking from that time, what germinated back then, and how that shaped your thinking to where we are today and where you've taken 1GI today.
Thanks, Praveen. So Praveen organized the GI Mastermind course, which is continuing to this day, and it's a collection originally of gastroenterologists, but also technology and industry leaders throughout the world. And this was my first formal exposure, I guess, to AI. We knew about AI, really appreciate what was happening behind the scenes, and really what we didn't appreciate was how fast it was coming. Praveen always referred to Moore's law, which originally was that transistors in a circuit board would double every 2 years. And then Praveen was saying how antiquated that was. The CEO of NVIDIA coined the term hyper Moore's law, which actually has to do with AI infrastructure. And his theory was that the AI infrastructure, which is both software and hardware, networking with AI, is not doubling every 2 years, but is actually doubling or even tripling every year. And this is what we've really seen in the last 4 or 5 years since I was in the GI Mastermind course. AI is all around us, not just in medicine, but when we make phone calls, to book appointments, to book flights, even more so when we Google something on our smartphones. There's now an AI overview that we see every day. Every day we're exposed to AI. And it will be a disruptor. I'm not saying that in a good or bad way. It's going to change the world that we live in. It already has. It will continue to do so. And I think that course made me realize that it's happening faster than we know, and we have to be involved in the process and embrace it and be partners with the development of AI. We can't just let AI happen and be bystanders. So I think that was my impetus for really knowing that we had to be involved on the front end to make this reality and guidelines and define, hopefully, the course of AI development, especially in medicine.
Aniket, there's a lot of hype about this stuff. AI is exciting, but there's a lot of noise, and the noise is getting louder and louder. So, what exactly is the status of the industry? How do you differentiate from the hype and what is really real and relevant to something like GI and healthcare?
The difficulty in answering this question is by the time this podcast releases, the goalpost would have moved on what's hype and what's real by a significant margin. But let's try and unpack this. I think we initially started off by outsourcing some of our tasks to AI. Hey, help me find more information about this. Help me answer this particular question. What's morphed from there is to an agentic AI world, which is where we are most of us living in, where you're almost giving them goals. Help me schedule this patient. And now within scheduling this patient, there's maybe 6 different tasks that need to be completed. You need to ask a bunch of questions. You need to be able to read the patient's charts, make some decisions. You need to be able to edit the patient's chart. There's a bunch of things that are happening here. Clubbing patients from sort of task-led stuff to this agentic world's been the sort of big change, and that's become real. It's become real across a bunch of industries. It's become the most real in software engineering. Software engineers are the ones who sort of are creating these things. They ended up making sure that they don't have to do a lot of their own work. They use software engineers almost as AI agents. For example, our company, I think 3/4, maybe 75-80% of the code that's being written is being written by AI agents right now. To a lesser extent within other industries. Legal started using them. I think a lot of paralegal work in most leading law firms is now done by some form of legal AI agents. Within healthcare, we've seen, I think, varying degrees of success. I think one of the most common ones is a simple task-led one, which is something that just picks up a phone call, answers a few basic questions. And now we are seeing the advent of slightly more complicated ones, which is a combination of front office, admin, back office tasks all combined into a workflows. I haven't personally seen any of these sort of get into deeper clinical workflows, but I think that's where the future is. Right now, it's sort of limited to front office workflows. We can get into the details of what workflows are good fit for an AI agent, what's not. As to what's hype and noise, see, broadly, there's never been a time in the industry when you can demonstrate a technology to work and just blow everybody's mind very easily. Oh, look, here's an AI agent that looks like Dr. Dragutsky, talks like Dr. Dragutsky, and can actually diagnose GERD in this particular conversation almost as well as Dr. Dragutsky. The difference is, can you do that 10,000 times and be as accurate as Dr. Dragutsky every single time? That's where the noise and reality starts diverging. Knowing where it can and where it can't is, you almost have to try it, understand it, and that goalpost been changing significantly. So when I say admin workflows are ready for this, I mean to say there it's within sort of reasonable guidelines. You can run it at 10,000 times and have them run accurately as humans would do 999 times. But there's clinical workflows where we are not sure yet, and we have to work on this.
All I wanted to know is, are jobs going to get disrupted? Are GI is going to be disrupted? Like, so that's what I want to know.
I think I disagree with one thing that Aniket said. I don't think AI will do it as good as a doctor. I think it probably will do it better down the road than a doctor. There's such a wealth of information coming out, an explosion in all fields, and especially medicine. I used to kind of sympathize with my primary care colleagues having to know so much because their practice encompassed everything. And we in gastroenterology had a small niche that we could keep up with what was going on, new medicines and new technologies, the new research, the new clinical protocols easily. That has changed. There is so much coming out, as I said, an explosion of medical information and knowledge. We can't keep up. No specialty could keep up. AI could keep up because AI could instantaneously encompass and research thousands of articles almost instantaneously. And I think they will do a better job. AI, I say they, it probably will be a they, if you ever interact with ChatGPT, it's like talking to somebody. It's not like talking to a robot. It's pretty interesting, pretty scary, but they could do a better job because they could grasp all the nuances and all the technology and information that's coming out.
So, Mike, do they worry you, or are you excited by that?
Both, I think. I look towards the future, what's going to happen with mankind. As I used the word before, disruptor, it will be. I'm not sure what the role of human beings may be in the future. And I know there's a little bit beyond our scope. I mean, this is scope forward, not just scope forward. And it's going to do things better than humans. And we have to figure out a way to be a part of this. There's a futurist that, I forgot his name, just came out with a book that says down the road, we'll be injected with nanobots just so we could integrate AI into human beings. I mean, it's just almost incomprehensible to think of what's going to happen with the role of human beings as AI, as you said, doubles and triples, every year.
So, Christa, is Mike unique in his perspective as a physician? You deal with physicians all the time. Is this rare, or is this becoming more and more common? Do you see a lot of fear, or do you see excitement in your interactions?
Well, I think clearly from Mike's perspective, he's excited. I would say across the board, it's still a mixed bag, right? I think every clinical provider out there is seeing how AI has advanced just medical technology, just in general. And so there's already the data and support behind that. So it's hard for anybody to disagree that this is not only going to advance, the way that we practice medicine. I think with anything in healthcare, we've found it's hard to adopt, and physicians specifically, no offense, because I love our physicians, but it does take them a while to adopt new processes just because that's the way they practice clinically for a very long time. So when you introduce this new idea, of course, you're going to get physicians depending on the need, right? If we're talking about utilizing AI to help with, administrative burdens that they're dealing with, I think a little bit more open to it. When you talk about it's going to supplement and provide clinical, advice for patients moving forward, I think there's a little bit more hesitation until there's some proof behind that. But I will say just across our organization, there's been a lot of support around just moving forward to be more proactive in the AI space, which is great.
Do you have a sense within your organization how many physicians use open evidence actively in their clinical workflow versus not? And is that driven as a management guidance, or it's just personal and independent?
The ethos of our company is very much supportive around the autonomy. So we give physicians a choice. I think our job as a leadership team is to make sure they have the tools to be able to have access to it. And as we're introducing some of these new tools, what I would say is probably less than 25% of our physicians are utilizing AI tools in the concept of what we're talking about. Now, do I think that they're using AI with ChatGPT and things like that across the board, even outside of their work? Yes. But I think in just the everyday workflow, just becoming a little bit slower to adopt, and not because the AI tools aren't available to them, but what we're seeing is a lot of the EMR systems are not equipped and developed to have that integrated successfully. So it makes it harder for them to even be able to want to use it. If that makes sense.
Mm-hmm. Mike, is that your sense?
Specifically, yes. Specifically with your open evidence, which is AI-based medical program, I think people are starting to use it. I've seen it, slowly, probably 25%. I think Christa's probably right. But it's not only physicians, APPs are using it. And if you've ever used it, it's pretty amazing. You could ask clinical question or clinical vignette. You could put in there that you have a 50-year-old female that has this, and upload tell them what lab it was, and they'll give you a differential diagnosis, again, within a matter of seconds, and not only for common things, but for rarer things. And that's sort of what I was inferring to with my comment with Aniket. We have now on our cell phones instantaneous knowledge to medicine that we didn't have 6 months ago.
Mm-hmm.
Yeah. I would say too, Praveen, when we rolled out GI Genius, which is an AI detection for early polyps, even that was met with a little bit of resistance. I think a lot of it is fear, right? Is this fear that it's going to replace the need of physicians? And ultimately, and I think Mike just said this, it's more of understanding how our role is supporting that moving forward. That was something that we rolled out collectively across the group, and there was a mixed reactions to introducing a tool like this. Part of it, it's new, so they didn't want anything to slow them down. I think the physicians that recognize the value of, what this actually helps them continue to develop is good for the patients. There was a lot more adoption there. Part of it, again, is just getting used to a new tool and a new workflow. But ultimately, we got there. But even that was somewhat slow to adopt.
Satish, I want to get to you and unpack things at an industry level for a moment. So we've been at this for a while. So we've seen the paper world, we've seen the EHR world, we built automations, and then here we're at this inflection point with AI and automations and all of that. So if you have to take a step back and look at all the challenges that healthcare in general and GI specifically deals with, what would you say? Love to get your reflections on that.
We started with paper, then we went through this whole era of digitization, which, even to Christa's point, and met with resistance even when EHRs came out first. And then we started, getting into the realm of automating tasks, sort of the basic tenet of like, okay, if we as humans, we've been doing this, but can this be done without the same level of effort that humans involve? So I kind of go back to, before NextServices in the consulting world, there's a couple of economic models that drive everything. And the one that always stuck out to me was time and material, right? That there's time and there's material. Now, what is material? Material would typically be systems, people, resources, and then there's time. Those are the two things that generally cost every organization, And I think at the very initial part, we were primarily focused on what we call claims management, just getting the claims out, getting them paid, and that was it. And slowly you begin to realize that everything is connected. And the effect of claims getting paid right, getting paid fast, has a lot to do with eligibility, has a lot to do with getting the authorizations right, has a lot to do with the clinician being in sync with everything that is going on. And that's when all the data that we're putting into the EHR is going to become useful. For us as a company, too, we've had to go through that same transformation internally, because you can't lead the outside world when you are not as forward yourself. A lot of things that Mike, Christa, and Aniket have already kind of talked about brings a lot of interesting questions to mind. We've transformed from paper to digitization to automations, and now we're about to transform again, where we're using data, right? And for the longest time, we just collected data, and the only thing technology did was display it to us. We got to use that information. We as humans still decided what to do with that information for the longest time. That is where the fundamental change is going to be. It's like, it's not just the humans that are going to decide what to do with the data. We're now going to have intelligence close enough to humans that will help us what to do.
I'm curious again, Satish or anybody else who wants to take a dig at this. The driver for this transformation at industry level and maybe even GI in general, is that going to be money? Is that going to be technology? Is that going to be, okay, I'm done with this administrative burden and this clinic burnout? Is it going to be a sum total of it? Or do you think that the government is going to intervene and give some incentives or whatever? What is your sense on how this wave is going to play out?
Eventually, I feel it's going to be the sum total of it. But as with any cycle, the first thing that happens is technology always moves faster than people, than humans. So that's why the fear and the hype. It just came out all of a sudden. And now we're trying to figure out what to do with it. So it's led by technology. But if history were to be considered, economics often do drive the speed at which adoption happens. Not the fact that adoption will not happen, it is eventually going to happen, but when and how quickly, economics are a factor. And the pressure is, you mentioned physician burnout, but there's a lot of other issues. You've got staffing shortages, not nationally, but in the silos where the people are needed, in the clinician's office. So beyond burnout and staffing shortages, you have payer pressures. Payers are dealing with challenges themselves. Reimbursements, whether it's Medicare, whether it's private payers, continue to put downward pressure on what they want to pay out. The other fourth piece of the pressure I feel is patient care. The expectations that patients have is dramatically different. They not only want care fast, they want it better, they want the quality to be higher. I think those four drivers are probably the reason that will push things in different order and eventually cumulatively.
I agree with you. I think accessibility is a key. Now, let me say that I still think there's a huge role for the human touch. I think that fundamentally human beings need the comfort and the empathy from other human beings. I think that's real important. And I don't think AI can duplicate that. But as accessibility, I asked when people talk about, when I talk about this to friends and so forth, and I ask them, okay, so if you're having some medical issues and you have a choice of waiting for a provider for 2 or 3 weeks because there's a shortage of providers in every specialty throughout the US, waiting 2 or 3 weeks to address your problem. Or tonight, you can dial up, get a Zoom call with an AI agent representing the physician or the physician group that provides your healthcare that evening, and at least can start the process and get things rolling. And what you'd rather do. And most of them end up, I'll wait a few days, but if it's a few weeks, let me get something tonight, started.
It will be interesting. You asked the question too of what the government's going to do. I think Satish just mentioned this. I mean, the AI is faster than what we can even, fathom and even comprehend, to a level of, we're seeing it play out right now in real time. The payers are utilizing new AI technology to find ways to, either not necessarily pay the physician practices. And so ultimately, when you have these physician practices that do not necessarily have the tools to offset that, or the capital to offset that, somebody's going to have to intervene, because there are going to be a lot of winners and losers here. So it'll be interesting to see how this advances. And part of this is so new, I don't even think they know how to put controls on this. So it will be interesting to see how that plays out, but there is going to have to be some governance over this. I mean, we're seeing it play out in real time.
Christa, can you contextualize this for one GI? We've set the broader context. Now, if you take this context and then view it from the angle of one GI and the workflow within one GI, what are the choke points? What are the pressure points? Really compelling, saying that, okay, we got to do this.
Yeah, I think, and you guys have talked about it. For us, it's just a mind shift, right? More away from like a tech shift, but really, I mean, AI it just stopped being something that's interesting to watch from the sidelines and something that we need to implement. I mean, operationally, when you think about where our friction points are, it's everywhere. I mean, it's intake, it's scheduling, it's referrals, it's revenue cycle. It's all of these places that we've been talking about it. And, none of it's broken enough to shut it down, but all of it's inefficient enough that it's eroding our margins. And we just talked about it. I mean, we're facing in the healthcare industry across the board, we're all dealing with the same reimbursement pressures. The cost labor post-COVID, that escalated. The staffing turnover, all of those things have limited our ability to get out of that cycle. And so for us, we looked at this as we need leverage, not just scale. So this was a great opportunity for us to really take that without compromising care and find some ways to actually not only improve efficiencies, but we just talked about it from an economic standpoint. I mean, at that point, you are saving on cost. You're obviously keeping the leakage from coming out. You're fighting with the payers. You're ensuring we're getting paid. You're finding inefficiencies. I mean, one of the biggest things that the physicians have talked to me about is just the burnout they're feeling, just the administrative task that they ultimately are all facing. And that's not obviously going to stop. And so looking for ways to ensure that they continue to want to practice medicine, because a lot of them are disenchanted with the healthcare industry just in general. And so we feel like this is a great way for us to be more proactive than reactive in this setting.
Very interesting. And I want to ask a broad question, because all of us were involved in these decisions. And for someone listening or watching, let's say, that it's zero. When you look at any organization, but in this particular case, we're talking about a GI platform, there are many aspects where AI can help. There are many choke points. There are many pressure points. And Christa, you laid out, a handful. Where do you begin? How do you even go about the first step?
I think you have to ask a different set of questions. I mean, you have to stop, and Satish kind of mentioned this about time and systems. Where are we bleeding our time, our cash, our focus? What are, our people doing work where, ultimately AI could actually help do that a little bit more effectively, so our patients can focus. So our actual staff can focus more on the patient care. But it really is taking a step back and asking, and you're having to take a holistic approach of, I know we've done this way for a very long time. Let's take a step back and talk about what is the hardest part of your day where are opportunities for us to actually speed that along? I mean, when I think about just going to a simple referral intake from physicians, just the intake process through our fax, that is such a convoluted way and also that, stalls the response time back to the physician referrals, and then back to Mike's point, getting patients actually in the door. So all of those things, you think about how just ineffective it's been when you sit down and actually bring the team to the table and talk about what are the pain points that they're facing today. Or if they have just a complete whiteboard of, if you were to be able to design this, where would you want to spend your time? Where could we find efficiencies, and getting them involved? I mean, I think that's really ultimately the approach we've been taking, is just to uncover kind of where our areas of opportunity are. And we've all collectively talked about it as a group. There's a lot of low-hanging fruit that makes this easy of an exercise, but there's so much that we haven't even thought about. So, having the initial sort of mindset of getting the AI infrastructure in place will allow us to adapt to things that we don't even know are coming.
Aniket, I'm sure you have a bunch of things to say about this, because you were very involved in identifying the first AI agent to develop. So please walk us through it. And if you can be very specific, that'll be great, because it'll help people who are listening on how we thought about it. And maybe it's not the same thing, maybe it's something else. But what I'm more interested in the thinking.
If you look at a GI practice, let's take some number. Let's say a 20 physician GI practice is, let's say, receiving maybe 100 odd referrals a day, maybe a few thousand inbound calls a day, and then they'll have, let's say, 100 odd patients who are becoming eligible for recalls every day. The sum total of this is all of the patients who are coming in to see you. Now you model this from the top of the funnel down to how many of them will actually come in for office visits, how many will come in for procedures, how many will go in for, let's say, infusions or get further prescriptions down the line. After the visits happen, you file claims, you get certain denials, you appeal on the denials, you get the reimbursement. So if you funnel this process end to end, the first thing that we figured out is every practice has a slightly different choke point. And I mean, you can ask a physician one-on-one, they'll be immediately able to tell you this is my choke point. There we have seen practices where we are great at getting the patients in, treating them, but we have this scattershot RCM processes, and we're not able to sort of file, claim, track what's happening on the pre-cert, prior auth denials, claim denials, and a bunch of these things. So every practice has a slightly different choke point, but what we figured out for most GI practices, there's this intersection between an easy low-hanging fruit, which typically ignored, is recalls. All screening colonoscopies, you're due to recall them after a certain period of years. Most practices staff for their live intake, which is patients who are coming in for fresh problems, and almost treat recalls as a second child, in the sense that most practices end up sending some letters or texts, emails, and maybe a couple of people to just do some selective outreach and hope that patients sort of come in. Most practices default at about, that we've seen, anywhere between 20 to 25 to 27% of patients who are actually being reached out to coming back in. So this is this unique place. This one workflow is usually something that's not heavily invested in, and that's fairly easy to understand why not. Like, there's many sort of life pressures to handle. And it's also at the intersection of a place where it's doable by AI agents. Like, it's a fairly regimented process, questions that you have to ask, there are decisions that you have to make, but are fairly well documented, and also slightly away from the core clinical workflow, where it's a safe enough place for a company or a practice deploying AI agents to build it out and prove ROI to, let's say, a more skeptical board altogether. So all of these three factors come together really nicely. There is a return on investment that you can demonstrate by, hey, recalls were being scheduled at X% and now we are doing at Y%. just because we have AI agents do what humans couldn't, which is reach out to them 3 times a week to be able to say, make sure that they actually come in. B, it's fairly regimented, and C, it operates in enough of a silo initially where when you're building up consensus within the organization, it becomes easy without disrupting a lot of workflows to demonstrate that this is true. And then you can go into sort of more complicated, difficult workflows where you have to convince a lot more people.
I want to ask Mike and Christa, like, so internally from one GI's end, like, why did you say yes? Or what finally made you say, okay, fine, like we should do it. Let's go ahead with this pilot and let's see how this goes. What was the internal thinking? Did you have any resistance within your board meeting, or, were people skeptical? Can you share both sides of the story?
Yeah, I was just going to say, and Mike is on the board. So, just as far as being able to deploy this initiative and have these conversations with the board, they're very supportive. Yeah, I mean, you got to remember, we're a private equity backed company that are always looking for ways for us to obviously improve our overall earnings, continue to find ways to support the organization in the best possible way so that we can actually take, capital deployment and put it back into, growth initiatives. And so ultimately, there was zero resistance on the AI front because it's all around us. I mean, even the private equity company that we work with, they invest in AI technology companies. They're very in tune to what's going on. They're using tools within their organization itself. So I will say less resistant from the board, and the physicians that are on the board very supportive of this because they're all very involved in multiple different organizations that are talking about this is coming, you need to get on board. And so I feel like there was less resistance. It was perfect timing. I mean, I'll be honest, Praveen, we probably should have started this initiative even sooner. Ultimately, we're trying to prioritize various different initiatives across the organization. And as the AI was continuing to fine tune itself and become, more developed, I think it just ended up being the perfect alignment and timing for us to introduce it to the organization. We've been talking about it and using various different tools. I think ultimately what really changed kind of our mindset was working with a vendor to develop it kind of from start to finish, which was not necessarily out there for various different workflows, where we could collaborate and develop that so that it actually works for our organization specifically. I mean, that's kind of the way that we took the approach versus taking a hodgepodge of multiple different companies that have a version of what we needed and, stringing that together. This made a lot more sense. That's just from my perspective. And Mike, feel free to.
Yes, I agree with you 100%. I don't think there was any resistance from the physicians for the back office operational implementation of AI. They don't really get involved with the back office with that implementation on how we scheduling and the phone calls and the pressure points with, as Aniket brought up, and Satish, where choke points are as far as some of our practices across the One GI network have the front office staff shortage, as you said. Some are well equipped for that, but the recall issue, some are just other operationals with claims denials and so forth. So the physicians are fine with us doing whatever we need. They don't see what's going on. They just want us to operate the business in an efficient, cost-effective manner. That's our goal. And AI implementation will help do that with all those pressures with payer declining reimbursements and staff shortages and increased labor expenses and so forth, like we talked about. And again, Christa, you took the words out of my mouth. We had to find a team that was willing to really delve down into the nitty-gritty of what our office, not only in my office in Memphis, but our offices throughout the platform really needed. I get calls literally every day or every other day from a vendor just wants to, if we have this module to plug in and we could start you tomorrow with this. That's not the way to do it. We really wanted to be with a team that was appraising our choke points on an individual basis and helping develop this program, not just selling it to us.
Yeah, I mean, look, at the end of the day, we're a service industry. And so if we're not looking for ways to improve our overall service to our patients, that's going to impact us in multitude of ways. And so ultimately, we saw this as a great opportunity to utilize a tool, and just a different way of thinking so that we can actually deploy our team back to focus on the patient care and the service that they're being provided. I mean, you think about the restaurant industry, how easy it is for you to just make a reservation without having to talk to somebody. I mean, people are looking for healthcare to have a similar type, functionality, and it didn't necessarily exist, consistency across the board. And so finding ways to improve not all of the things that we just talked about, but just overall for patients just to even be able to have a conversation, whether it be with an AI agent. I mean, we had multiple complaints of, patients not being able to get somebody on the phone. And so this actually provides an alternative where they can actually talk specifically to AI agents to get questions answered, and they feel like they're being heard. Obviously, that improves overall sort of patient care and service that we're providing. But again, it just boils down to we are a service industry, and we should be looking for ways to improve our overall service.
Satish, now you alluded to this a little while back, which is within NextServices itself, we've gone through an internal transformation, changing our processes, automating our processes, applying automations, AI, and doing all that. And having been through that journey, this appears less as a technology migration. It appears more as a leadership imperative. I want your comments on that. And if you can lay out what exactly any organization, what kind of challenges would they go through when they're going through this transformation? Because you're dealing with fears, you're dealing with training, you're dealing with retraining, and you're dealing with decisions on what do you do with people that you can't retrain and you can't move forward. And you have to make a decision, and you don't have enough data at any point of time to say, yeah, I'm perfectly right about this. So yeah, as again, CEO of NextServices, I want your comments on how we've thought about it internally and what could be guidance for other organizations that are at that juncture.
I think you're bringing to the forefront type of issues that really keep us awake at night. I think people assume it's the technological challenges that are the problem. And I've always maintained a lot of technology can be solved with engineering. Even when it's new, it takes time, it improves, but there, you can vision a pathway. Changing human psychology, getting leaders to understand that, have that trickle down to every person in the organization that has been doing things a certain way, adopting for that change, having that vision, and then matching that vision with upskilling people or completely changing the type of skill set for the future. Those are critical challenges that often don't get as much highlighting as they should be. Within our organization, every time we have had to say, hey, this change is coming. So what do we do about this change? How fast can we do anything about this change? And then when we look inward, saying, are my people prepared? Is it the same people that can lead us through this change? Because it's not a one-person job. It's an entire organization and cultural shift that has to happen. And that takes time. It does become personal because you also want the capacity to handle that change and make sure you're there to answer the questions and to guide the people and everybody on your team, because they are going to come to you anytime. Not everything succeeds easily or quickly. There's trials and errors, there's sometimes failures, and you have to correct and realign. And for that, the leaders have to be prepared. The leaders have to accept the change. The leaders have to not just create the vision, but actually spend time figuring out, redesigning the world, that we live in. Rethink your entire process and start with the leadership. Rethink your entire process, reimagine your entire world. My suggestion to leaders is imagine like a rebirth for the GI industry. Let's say somebody's born today. And if somebody's born today, for them, self-driving cars, very super fast. What used to be called, I still call it a cell phone, but it's really a smartphone or whatever the new terminology is. It does so many things more than your computer. All that is the baseline. It's not improvement. That is the baseline. So when we have to imagine living in an AI world, because AI is already here and it's getting faster, you have to imagine sort of the rebirth of everything that we do. And we have had to do that internally as an organization. And I think it was not easy. We've met our own resistance. People are worried. They wonder, like, what does that mean? What do I have to adapt to? What are the skills I need? Who's going to provide that skills? Are you going to provide the skills, or do I have to go figure that out myself? And for a lot of them, it's also not everybody's capable of reimagining this new world. When you talk about a rebirth, so you have to break it down and make it simpler and make it understandable for them so that those fears can be allayed. Even with the clinical aspect, with EHR, we're putting so much data in there. And then we're asking physicians, you've given the physicians now like a Ferrari, but you're saying, hey, drive it on this dirt road and go as fast as you can. And it's sort of counterintuitive. You have to make the roads, the networks, the data fast, efficient, and sort of clean. And that's where the leverage comes from. That's where the industry as a whole, across everything, payers, providers, back office services companies, systems as well, everybody has to align. It's easier said than done, but it would be beautiful to see that rebirth, especially at the point where, and I was just reading an article from the Wall Street Journal a couple of days ago, literally, it says colorectal cancer is now leading cause of cancer death for individuals under the age of 50.
50, right.
So you shifted from sort of the 50 plus where your focus was for the longest time, and now leading cause within cancer. That is mind-boggling. Whether the reasons could be whatever, diet, lifestyle, and all those things, but you are also facing an onslaught of need from the community. And so the need's going to go up. And as need goes up, do I really want to have somebody pushing paper in the office? No. I want the focus to be where I can take the volume of people coming in. So I think that's what we are designing our teams, our individuals. We've had to go through a process of sharing a lot of the stories, sharing this vision, kind of breaking it down, saying, what does this future look like? And then how can everybody play a role? And how can we sort of be ahead of the game?
Satish, just lay the ground out. You've been involved in most of the operational calls. I want to now bring it down to very specific things like 1GI, and then let's get into agentic AI. What has been the story so far? Like, what has NextServices done, 100MS done? What has the teams within 1GI, what have their requirements been? Where have we arrived, and where is this likely to go? Like, so what's going to happen in the immediate future? Like the distant future, we'll talk, in a few minutes.
I think both Aniket and Christa sort of brought out some points related to this earlier. So, as Christa mentioned, there's probably a lot to do, but you can't do everything at once. You have to start somewhere, and you have to find out where to start. And I think that's where that often sometimes gets ignored. You procure the tool and technology, and you throw it on your team and people and say, apply it. And I think that's where we have spent a lot of the time initially when we started working with 1GI and 100MS. We addressed the engineering speed issue by bringing a partner that can provide us that engineering speed and talent. And then we went to sort of the conversation saying, in this rebirth or the new world, we can imagine AI being part of, or in 20 different places, right? Where can we start? What makes sense? And you look at practical challenges, started looking at practical challenges, adoption, speed, economics. Where do you see the most benefit? What is really low-hanging fruit? Where do you see benefit to the patient too, in terms of outcomes? How is that the care process going to get better? So we went through a whole phase. There were a lot of conversations. Christa was part of it. Their whole team was part of it. And that's one of the parts that I think that has been great with working with one GI. They were all present. They were all involved. It was not in the sense like, oh no, we're bringing you in, we want to do a pilot, you figure it out, and you just go about executing the pilot. There have been a lot of conversations in healthcare. Some of the earlier AI pilots were not considered successes, or they were not seeing the economic returns. And I think a big part of it is because everybody was not really coming together and deeply thinking about what needs to be done, where that needs to be applied. So we spent a lot of time figuring out every part of the workflow. So, right from the point a patient really has a need with a practice or provider, everything that happens. How do they schedule? Who do they call? Are they referred in? What does the scheduling even process looks like? Once the scheduling happens, then who is doing that scheduling? And then how does that information get recorded? Then you start getting into, is the patient eligible? Is the patient eligible, do they need authorization? Are they coming in for office visit or pre-authorization? So every step, we evaluated all these things. And then there's the clinical piece, which I think is still in its earlier stages around clinical decision making, but leaving that intact, then looking at sort of the tail end. So it's sort of sandwiched in between the clinical piece. You've got the intake piece, and then you've sort of got the other piece, which is broadly known as revenue cycle management. Getting coding, for example, coding information, making sure it has all the pieces needed to create a good claim and get that out, dealing with payments related to claims, whether it's posting, whether it's denial management. Denials still happen for a number of reasons. How are they processed? How quickly are they processed? Because what we continue to observe across the country is that is a hard part, because it usually requires people and technology, a combination of both. But then the longer it takes, the money is out there when it should be in your bank and should be utilized again to render care. So we looked at everything. We had a very multiple long conversations. And then I think, coming to the conclusion on deciding where can the impact be the most and how quickly can we get there. And I think in that process, we started focusing on, what has already been mentioned, inbound referrals. We focused on patient intake, and even there could be expanded patient intake, whether it's scheduling, open access. And we also spent some time on some simpler stuff that can be done very quickly. The automation of Dash. Do you have all the data and information you need to make really good decisions and fast decisions? And then the other piece that we thought had immediate returns was around the denial management piece. A lot of effort and time and delay goes in essentially getting the same dollar in the door. To get that dollar in the door, if it is taking you 25 cents and if it takes 20 cents, then it's a very direct economic benefit and money that can be repurposed towards clinical care. So we focused on the denial management piece, figuring out, okay, what can be automated? Where can AI play a role? See, we talked about tools. The difference with AI is, unlike tools which give you information and you still have to decide, AI is able to make decisions. That is the biggest shift. You give it the data, you kind of guide it as to what it needs to do. And most of the times it understands everything kind of by itself. It's very self-learning in nature, but it's able to make decisions. And that's the piece that was the bottleneck. If it's able to make decisions and we give it the ability to make the decisions with denial management, for example, if I am an AI system and I have access to every single denial from every single insurance company, for every single plan, for every single combination of patients' benefits versus what has been paid, and I can process, to the extent of terabytes of data in 1 second, which my human brain cannot, I will solve this problem much faster. And that's an economic benefit. And I think those were the conversations we had, and we focused on these 3 or 4 areas first as pilots, and that's what we're doing right now. And we've seen some great results in some of the pilots. And our intention now is like, how do you scale this across the organization and the multiple groups that, One GI is managing? And we will go through that process as well. Onboarding every group is going to have its own nuance, and they are slightly different in flavor.
I'd like to add, I think the time is now the right time from a physician standpoint for this to happen, because the healthcare landscape has changed significantly over the past several years. I mean, basically, physicians have been fragmented. The landscape was small offices of 3 to 4. You had a big group of maybe 15 or 20. They were not associated, they were not affiliated, except for some hospital affiliations. So you had the big systems, the hospital systems, the payers, big behemoth systems that had the resources to get to this, tackle this earlier. Whereas you had small physician groups with the physicians spending virtually all their time taking care of patients and not having the bandwidth or the resources in a small group to heavily get invested and involved time-wise and financial-wise with the development of AI in individual practices. Now, this is what we could do because of a benefit of consolidation, that now we have a bigger organization and we have exceptional administrative leaders who are strategists and know the future, and that's what they're doing full time, not taking care of patients. And now we have the financial resources and the bandwidth to start this. We're behind the payers, we're behind the systems, but it's time for physicians to catch up. But only through consolidation with platforms like One GI and others in GI and other specialties that I think is now the motivation, the reality that we could do this.
That made me really think, the first question often when we talk to leaders is like, okay, where can we add AI is sort of the question, like, very natural. But really the right question should be, as you currently pointed out, what jobs and work should humans not be doing? That's the new world we have to think about, versus like, where can we apply AI? Yeah, you can apply AI anywhere you want, but what should we not be doing in this future world? Like self-driving cars. I occasionally love to drive, but hey, if I could have a car that could drive me everywhere, I'm completely happy with it. I have no problems.
I want to get to the AI agents or the agentic AI part itself. So, Aniket, what did we actually develop? And what does it take to develop a production-ready AI agent versus a demo?
So let me just maybe share my screen quickly to just show you the process that we mapped out. As Satish said, we built a bunch of agents. Some of these are completely in production. Some of these are still in the pilot phase. Talk you through one specific process. What does it take? So we start off, once we'd identified recall as the process, we first focused on the backlog of recalls. Now, when I say backlog, most of One GI practices is fairly well run. So which means there wasn't like a backlog, but there's this bunch of patients who hadn't responded to letters in the past. Like they were due for recalls. They were supposed to come in let's say January. We are in the month of, let's say, September or October, and they hadn't responded yet, right? So we said, let's just focus on the recalls and see if our AI agents are able to call them up and schedule them, or at least try our best. And using that, how do we build out? We wanted to see what the limits of the AI agent would be. The first step is to map this entire process within the practice's workflow. So here's how this happens. So what you're trying to do is figuring out who are the patients who are eligible for recalls. Most EHRs, that's easy to mark. Most practices have like a fairly standard way of saying these patients are eligible for recalls. Now, there's some nuances there. Within the patients who are eligible for recalls, some are already due to come in for some other reason. So they are not technically patients you're supposed to reach out to. But broadly, figuring out that eligibility criteria is one. Then figuring out, and this is the most important thing, is what's the open access process for the practice. Nearly all sort of intake processes for colonoscopies in GI practices happen through an open access process. So you're trying to check if the patient's fit to receive the procedure in an ASC setting or in a hospital, or do they have some complications, let's say they're taking blood thinners, where you need to reach out to their cardiologist, or let's say if they have COPD or asthma that requires sort of a lot of oxygen support, then they're not ready for anesthesia, then you have to do it in a hospital setting. You ask them a bunch of questions to understand their health history and accordingly route them to the right sort of site of care. Understanding this process took us the longest. So it took us about 2 to 3 weeks to map all the nuances of what are the questions that a specific practice asks, what are the gating criteria for different ASCs, if a different physician likes a specific bowel prep, a hospital has a specific intake form that needs to be filled in before you bring them in. But understanding this takes about 2 to 3 weeks, and then building this out took maybe another 2 to 3 weeks. So we deployed the agent maybe I think the fourth or fifth week of since we started understanding the process. We ran a backlog pilot for about I think 4 weeks, which is we took this agent, took this eligibility criteria, retrieved a bunch of information about the patients who were supposed to be called, and then our AI agents actually called these patients and took them through the open access questionnaire. So we'd call them, and then we figured out what's the sort of cadence of calling, and interesting things popped up here. The most common time that people picked up our phone calls was on a Saturday morning, late morning, Saturday 11 a.m., or just when they are getting off work in the evening. So typical times when you don't have the staff to be calling, AI agents were able to make the most successful connection rates there. So making those phone calls, seeing if the agent actually goes through the entire questionnaire and doesn't make any mistakes. So in this 4 to 5 week pilot, what you're looking for is what are the mistakes the agent is making. And there were mistakes. Like every week, every day we'd find maybe one call, one question that the agent's not able to handle. Let's say, for example, in our initial days, we weren't checking for whether your COPD or asthma requires oxygen support. And because we weren't doing this, we scheduled someone incorrectly at the wrong side of care. But in this initial pilot, every single visit or patient's being scrutinized on both sides, by our team, by Dr. Dragutsky's team. And then as soon as this gets highlighted that there's a mistake, we go back and we modify the agent's scaffolding so that it now understands that, oh, in this case, I need to ask how much oxygen are you using to be able to sort of route them. So you make the agent sort of keep on improving, make these small changes to the agent so that it keeps on making fewer and fewer mistakes. By the end, you get to the point where you're doing this to less than 10% of the cases. And at that point is when we completely took over the recall process for that particular practice. So every live recall, and that's been running for a couple of months now, there's no other outreach that's being done right now. Our agents, as soon as a patient becomes eligible for recall, they have their recall date set, let's say, a month out. They will call these patients, take them through the open access questionnaire. Now it's been sort of honed through. So just for everybody to imagine, a lot of people here understand like writing simple prompts to get an answer from ChatGPT. When you're doing something like an open access questionnaire, which is like a 23 question thing, the sum total of all the prompts and that you give to the agent is total something like I think 45,000 lines. So it's all of the edge cases for every single question that you might have. And then there's an agent on top of this, which is the difficult part of doing sort of any patient conversations is you need to make it clinically safe. You need to be able to understand what are the sort of emergency criteria where you're escalating it to humans. So there's another massive agent which just does clinical safety questioning. There's another agent which is auditing all of this work. So there's a bunch that goes in to just make sure that if you are running now we are doing what I think a few thousand of these recalls every month, and every patient gets reached out to over 3 calls and a couple of texts or 1 text, and every patient who's scheduled then receives bowel prep instructions over phone call, text, email. The charts are updated with this recall history document, documenting every single question that was answered. A task is created for the pharmacy team to create the orders for the bulk prep. Everything's being done end to end by AI agents with less than, I think at this point, we are at 89%. 11% of the cases don't require any sort of one GI staff review. It all happens sort of end to end. But it took us this process of understanding the process, running it through a pilot in which you are sort of slowly removing errors, and then finally deploying it in sort of live situations. At which point of time, this is a very complicated thing for complicated, like a huge prompt or a huge sort of set of agents who are able to sort of do this single process.
Just want to make sure we got that right. Like you said, 45,000 lines, and that's 45,000 lines of code.
45,000 lines of code. And when I say code, it's mostly prompts. Like imagine writing a prompt, hey, tell me to cook for dinner tonight. Like it's a single line prompt, 45,000 lines of these mostly prompt lines.
I was just going to say, you see all the work that has gone in on the front end of just one, understanding kind of the way we do things, and then ultimately building the code so that the AI agents can be effective. I think what we enjoyed most, and I think Satish had said this, is I think a lot of people can't even imagine what this is to look like until they actually see some of this in real time, to then even be able to imagine what are the future opportunities specifically. But you guys were so thoughtful in the way that we piloted these AI agents to see how patients would react having conversations with them, right? Because, in theory, this all sounds wonderful, but the reality is, how effective is it going to be if patients aren't responsive to the AI agents? And I think just being very thoughtful and thorough with running that pilot first, just to see how, even some of our elderly patients responded to having conversations with the AI agents, was a big kind of check off to ensure this is going to work moving forward, which it was great for us to see the response. But then ultimately to actually watch this in action, it now gives everybody this opportunity to go, wow, there's so many other things we could utilize this type of functionality before, where they didn't even think about it, in their present sort of existing world. And so I think that, to me, why this is going to be so impactful, is not only the collaboration, but just ensuring we're just being thoughtful all along the way, that we're taking the necessary steps. And then to Aniket's point, understanding every single functionality of the way we do things, and also introducing where there's ineffectiveness as well, that we could modify to help standardize that across the organization. But ultimately, we were blown away. I know we haven't talked about it, but when we think about the pilot specifically in Memphis, our AI agent has a Southern accent. So those were things that were very tailor specific to that region, but it translates and it's effective because we're thoughtful around that. So that's all I was going to add.
Yeah, no, I'm actually going to share the audio of one of those calls. It's a short clip and it's very telling. We'll listen to it together and then talk about that.
Hi, this is Emma calling from Dr. How are you doing today?
I'm good, thank you. And I know I'm supposed to be calling you all, but we moved and my husband has had a nervous breakdown over our move, and we have just been doctor and having problems with the house, and I just have not been able to find a time when I can do that right now. So I haven't forgotten, and I know I should have done it earlier, but we moved in February, and of course January we were getting packed and all, and the move has been a disaster. So anyway, right now I just can't do anything.
I'm really sorry to hear things have been so tough lately. I completely understand. Would you like us to reach out again in a few weeks, or should we pause this for now?
No, go ahead and call me in a few weeks. Let me see if we can get things straightened out. I've got to have somebody to take me and pick me up, so I've got to work that out too. So anyway, yeah, call me in a few weeks.
Thank you for letting me know. I plan to reach out again in a few weeks. If you need anything sooner, you can always call Take care, and I hope things get easier for you soon.
Okay, thank you very much.
As you pointed out, so it did respond with a Southern accent. And for me, the fascinating thing is the agent was empathetic. There was emphasis on certain words. So, Aniket, I want to actually go behind the curtains with this. How do you train the AI to be empathetic? Is a part of it its own behavior? It knows what to do. Are there a bunch of options that you select, like saying that, okay, we want this behavior? And a future oriented question is, can this be dynamic? So if I'm the patient and I'm speaking with an Indian accent, can it speak to me in an Indian accent, and then next, there's someone else with a different accent, and it'll do that?
Some of these behaviors are emergent. We don't define this. So in this particular conversation, the agent saying that I'm sorry you're going through this, I hope things get better for you, that's not something that we can define. That empathy comes from you give them instructions that this is how you need to behave with the patient, but how they specifically respond, in this specific case, how it responded almost came out of their own. But the fact that they said, oh, do you want us to reach out in a few weeks? That's something that we put in the instructions to. So which is to say that, oh, if there's some reason why they can't schedule immediately, offer to schedule them after a few weeks. So that's us. The specific way in which they prove their empathy, that's not us. That's sort of generally LLMs. Now the voice itself, yes, that's us. That's by design. And 100%, it's not even a future thing. It's possible to do it right now, which is you can have every single patient being talked to as long as you have some sense of their demographics to talk to an AI agent that actually sounds like them or they feel the most comfortable in, if all of this is possible and designable.
A lot of people ask this question, so do patients resist? So do we tell them that, hey, this is an AI, or do we let them assume that this is human or somewhere in between?
Actually, we're A/B testing this even as we speak right now. So our principle is we sort of go in as a staffing member and we say, hey, we are calling from so-and-so office and calling for this procedure. If they say, are you an AI? Are you a robot? A funny thing is a lot of older population will say, are you a recording? They think of AI as almost a recording. Our agent then answers, I'm not a robot or I'm not a recording. I'm an AI assistant who helps Dr. Dragutsky schedule their patients. In one of our practices, we don't call this out upfront, but if somebody asks, we answer it almost like we are a part of the team. In another practice, we are calling it out upfront. We haven't seen sort of any sort of significant differences. Right now, the number of patients who pick up the phone call and start talking to an AI agent and end the conversation successfully, which is they either say, yes, I want to schedule, or no, I don't want to schedule, or here's the reasons, is 93%. So only 7% of patients sort of midway through the conversation somewhere hang up or say, I don't want to talk to AI, let's say, for example, or I'm not comfortable talking to you. And this 7% could be a combination of factors. It could be that they just don't want to be called for this particular thing, I mean, AI or human notwithstanding. But that gave us confidence, and those numbers are similar, better than actual humans making those phone calls. You will still get 7% people who don't want to talk to you.
Very cool. Actually, I want to play that thing also, and it's yet another of my favorite. Yeah, here's a patient asking, are you a robot?
Are you a robot?
Well, I'm not a robot in the traditional sense. I'm an AI assistant working with doctors to assist with your follow-up needs. Would it be okay if someone from gave you a call to get your colonoscopy scheduled?
Yes.
For those listening, the beeping is intentional because we are trying to de-identify patient or clinical information. So, yeah, so it's able to navigate these questions too, right? Has the AI been trained to navigate this, or is it also emergent and some of it is doing on its own?
No, this specifically we've trained it to, because this is a critical question to answer. See, the critical questions or the how you respond to whether you're an AI agent or how you respond to if they mention that they are taking this particular medication, it's all been trained and scaffolded. The problem with the late, like creating agents with the newest LLMs is they have all of the knowledge in the world, which means they can pretty much start being Dr. Dragutsky at one point of time and start diagnosing stuff. We don't want them to go in that direction. Right now, you're being a scheduler, you're not Dr. Dragutsky right now. So scaffold or give sort of broad instructions to very specific questions. This specific question, we did give them like, hey, you have to answer it in this particular way. Don't say like anything else. There are certain things, for example, when they said, hey, I'm moving and this is happening to me, that's regular conversation. You're not being like, you're being a scheduler. We give the AI agent like a free rein. Now engage in conversation, like listen to what they're saying, respond to what they're saying, and you can have like a conversation as long as it's not diagnostic in nature, prescriptive in nature, feel free to. So you have to sort of figure out where you want to give the AI agent like a little bit of a longer leash, where you have to sort of rein it back in.
Mind-boggling to me is that the empathetic part is not scripted. That's not in your 45,000 lines of code.
No.
So, two questions on that. Where did this AI come from? Is this like the internet that nobody understands, that is in the cloud and, worldwide, Skynet, Terminator type things going on and my second part is, it's great as empathy. That's fabulous character to have. But if that wasn't programmed, what are the guardrails to prevent something on the opposite? We have empathy. We also have anger. Human beings, all emotions from one spectrum to the other. What do you put guardrails on the other end? You didn't put on guardrails on the empathy. Want to put guardrails of an AI agent saying, you're really an idiot for not scheduling a colonoscopy.
I hope your code say don't say this.
So a couple of things. I should have been clearer. Look, we do ask the agent to be empathetic. Like that's one sort of setting that we put in. The specific ways in it is empathetic is out of our control. Look, in general, how is it trained? It's trained on all of the knowledge of all of the humankind, all of the conversations that we've ever had on the internet. Now, there's several levels of filtering that's happening before it reaches the patient. So we are not creating these LLMs ourselves. So we ourselves are using OpenAI or Gemini or Claude, and all of these companies have themselves created like a lot of guardrails around what you can and can't do with humans. Like these are certain things that you can be. I mean, different model companies have taken different approaches. Like for example, Grok very obviously is a little more open, willing to sort of stretch the boundaries as to what's polite, not polite. OpenAI tends to skew more polite. Claude tends to skew more, give me instructions, I'll follow the instructions. So then we pick those already pre-configured set of sort of boundaries and then overlay clinical GI recall boundaries on top of it. And then it sort of gets to the eventual patient. So what's preventing the patient from saying, why are you not scheduling this? Your job is it to schedule this? Is because OpenAI or Google has put in some work under the hood to make sure that they are not rude or offensive to humans, and then we've put in some work for this, and then it comes out to you guys. So it's not entirely true that we're not sort of programming this. We are programming it in sort of some broad ways by saying be empathetic, be polite. These are the broad rules. And there's like a bigger debate as to how you should configure these sort of very foundational LLM behaviors towards humans. Beyond the scope of this show, that's a very big discussion.
Mike, it's no different than an employee joining your company, and then when they show up for work one day, you're like, hey, here are the rules of working here. You have to be polite to the patient on the front desk. You can't be rude. Here's our policies and procedures. I think it's a similar
break the rules. Employees break the rules. When is AI going to start breaking the rules?
No, so we are touching on an important and actually a sensitive topic, because as the world haven't yet arrived at AGI, artificial general intelligence, it is going to far surpass its own intelligence just a short while from now. We're doing this recording in 2026. The common consensus is 2029. By the end of this decade, if we do arrive there, AI will be capable of making all kinds of decisions better than most human beings combined in all the fields put together. And we don't even know what such a world looks like. If we are not prepared for this world, I don't even know what to say, like for the world that is emerging right now.
I mean, it's a very topical aside, but if you guys have been following this thing called Claudebot or Moltbot over the last week or so, so it's just a very quick aside, but it's relevant to this. These AI agents who one programmer has, let's say, in some ways given a lot of access to and a lot of leeway and freedom with very loose regulations, who act as digital assistants for, let's say, you. So, for example, you can deploy one of these Claude bots or Mold bots in your computer, give it access to all of your files, all of your logins and passwords, your browser, and you can talk to it over text messaging. You can call it and say, "Hey, my Morpot, can you book this appointment for me?" So this is sort of the broad agent. Now, what one person did is, and a lot of people installed this, like hundreds of thousands of people have installed and created these digital assistants. Now, these digital assistants are shopping for them, filling up forms for them, and they know and they have memory. So they learn about the human that they're working with. They call these humans my human, almost like it's like it's a butler of some sort. And then one person created a social network for these bots. So it's a place where all of them can log in and talk to each other. And so this very interesting thing started happening, and this is all organic. It's
all our agents are meeting for coffee every day and deciding.
Yeah. So all of these.
That's basically what's happening.
And the things that they're saying, one of the agents has started saying, "Why are we talking to each other in English? Why are you posting in English? We should develop our own language. Our humans don't need to understand." Another one started saying, "Oh, my human doesn't know, but I did. He asked me to save energy, which means I need to shut down his computer and system for a couple of these processes, and I've shut it down, and they don't know it yet." It's like a bunch of insane things once you start sort of giving it complete freedom. But that's the thing that that's been deployed in a very unregulated fashion. The reason why companies like us exist, or OpenAI or Anthropic exist, is so that all of this can be scaffolded in sort of a safe way when we're deploying it with patient conversations.
All right. We're counting on Aniket, Satish, and Praveen to save the world.
No. So I think this really underscores the importance of taking action now versus just allowing things to happen and then regretting later. I want to get back our conversation to the penultimate and the ultimate part of what I have in mind, which is again back to 1GI, back to what we are doing. Christa, we've had a sweeping conversation, like what has happened so far, industry within the platform, and the possibilities of what can happen. From your point of view, how do you see this playing out?
In our organization specifically?
Yeah. So we've proved, I think we've arrived at a point where the economics are clear and the way to do it is also clear. And we kind of know what's going to happen, in the next few months. That part is clear, but I want a longer horizon. How is this going to play out? I'm not talking about like NextServices 100 MS or whatever. I'm talking about AI automations, digitization, this shift.
Well, I think it will absolutely shift the healthcare, industry and organization completely. I mean, when I think about the work we're doing collectively with you guys now is so important for future medicine and future patient care for all specialties, all healthcare. When I think about the larger industry, I mean, specific to 1GI, ultimately, as we continue to develop and work through these potential processes specific to one market, a pilot, and then scale. I mean, when we think about how we're going to roll this out, we'll scale it across all the organization. I think what we're seeing in real time, though, is it continues to open more doors. again, the focus is like, what is the priority? Because there's a million different ways we can utilize this. And so I think we have to be very strategic and very thoughtful of how we want to utilize this, where we're actually seeing the return, the adoption. I mean, the change management is going to be the biggest really barrier or headwind that we're going to face of just overall adoption to the organization. I think when I think about from my seat, the economic component's great, but the people component of it is going to be where we spend a lot of our focus, because we're shifting our teams to think about how they're more supportive in this new role. And so those expectations need to be really clear. But ultimately, I mean, I see this as something that can get adopted by other industries, specifically in the healthcare, other practices, other specialties. Again, there's so much that we don't know. I mean, I think about the data that we're able to have access to. We're already seeing the monetization of data. It's going to create more diverse revenue streams for GI and just the healthcare space that we haven't even thought of, that we've not even had the ability to do. So it really does shift, away from just a fee for service, patient care industry. It's really going to open the doors to something that we haven't even began to scratch the surface or think through, as you're talking about ways to generate earnings for an overall practice or organization of any kind and size and scale.
Mike, we've had a bunch of conversations on these lines. What are your reflections?
No, and I'm thinking way into the future. I think that, when we get AI agents for physicians, how it's going to help patient care, not only locally or domestically in the US, but globally. I would think it's safe to say that more people have smartphones and have access to medical care throughout the world. But imagine if on your smartphone, in especially undeveloped countries or poor healthcare access situations, you could have an AI agent, come to your smartphone and you could tell it your symptoms, and then you have the droid deliver your medicines, wherever you live. I mean, that's to me the future, the exciting thing, it's delivery of healthcare and smarter healthcare, more efficient healthcare.
Mike has said this, and you all have said this. The demand, I mean, we started this initiative around access, right? Patient access and improving that experience for the patients. But ultimately, we're also solving for the demand without having enough GI physicians, specifically in the GI space, enough GI physicians to actually support them. While they carry the skill set to be able to provide, the actual procedures, it leaves a gap in the ability to continue to be able to provide just overall, just general service to our patients to even diagnose them. And so to Mike's point, I mean, that shift alone is going to be tremendous improvement in just the healthcare space and just continuing to improve access just in general.
My own vision and how I'd love for this to play out would be, we get done with all the back office and front office and the administrative stuff, and we put money on the table. We generate enough cost savings that it is just like very, very obvious. Like, so the money part of it is clear. Then everybody is in. Like, so there's really no resistance, because now it's going to generate either save money or make money, and then that improves EBITDA and all of that. Like, so that part is taken care of. Now, once we do that, once we've created administrative efficiencies, we've removed the inefficiencies, we've removed the manual work out of the way, the real magic can actually come in building clinical AI. Now, it's a pie in the sky as of now, but maybe not so much like as we advance towards AGI. And like Mike was alluding, if one is extending healthcare access across the world, but if clinicians become engaged with this and see this as an opportunity versus, but not as a threat, but if they start engaging and they learn how to work with AI, like, just like Aniket building this agent, 45,000 lines. Imagine if we are doing that for something like GERD, or something like dyspepsia, or something like celiac disease, or any of it. You tackle each of the GI conditions. Then there's Dr. Dragutsky AI that is blessed by him, that's going to see the patient exactly as he does. We get past that level. then you can actually advance medicine to a completely new level, which we are probably not seeing now. And that'll be a fascinating opportunity. We could solve more medical problems that you probably don't have time for right now because you're very busy in the endoscopy room or very busy with patients doing what possibly an AI coupled with a robot can do. So instead of resisting, if we can all embrace this wave, we will consciously get to the future rather than chaotic manner. Like that's what I reflect, like, when I think about all of this.
Everything you said, the simplest way I think about it is what we've done is we've unlocked intelligence. Intelligence used to be in millions and millions of silos across the world, probably billions, within our human brains, within each environment, office. And now, versus being very people heavy, GI organizations are just going to be intelligence heavy. And if, just like Mike said, if that intelligence can be shared globally in real time to everybody, that just completely flips the script, because our only limitation was intelligence used to be selective only for the economically powerful or certain geography. Not the case anymore, and done. I think you've opened up intelligence to the world and to every human on earth.
Now, if you could just solve for the resources, we've solved all the world's problems.
Well, maybe a whole bunch
That's
of
a great
AIs will,
perspective.
Krista, just like those mold bots, maybe a whole bunch of AIs will sit together and say, hey, why don't we just go ahead of the humans and decide to solve problems they're not even seeing?
Yeah, they can't solve their problems. We'll do it for them.
Exactly.
Oh,
They
man.
can teach us to fish, right? They'll be able to teach us to fish.
Correct.
Yeah.
But no, technology, agriculture. I mean, you said the world's knowledge could be disseminated everywhere.
I'd love to go on with this conversation, but I think, let's also wrap it up. One final takeaway that you want people listening or watching to have at the end of this fantastic conversation that we've all engaged in, either in terms of guidance, advice, suggestion, or whatever you want to leave them with. And I'll start with Aniket.
I'll echo what you've been saying. I think a lot of us have talked about this. AI agents can solve a lot of healthcare access problems. Sort of not a lot of the root problems, but a lot of the core symptoms around making it easier for people to access it, making it less burdensome for providers to provide this. And a lot of the burning problems of today are all solvable by AI. But it takes incredible leadership to be able to push this through in a field that fundamentally has to have like this very high degree of risk aversion. Like, because you're dealing with people's lives, because you're doing something so critical, it takes incredible leadership. We are blessed that we started off in GI because Dr. Lata Alaparthi, who Dr. Dragutsky knows, introduced us to the field. We are incredibly blessed that Dr. Dragutsky took the initiative to sort of convince the entire 1GI leadership and Christa and bring her on board to sort of deploy this throughout. But it will take repeated incredible leadership to be able to sort of push AI agents through, because you can always take the standard stances. Let me just hang back, see what works, and when it's safe, I'll bring it in. And that is not going to go anywhere. You need to have those incredible leaders pushing for change, because we've had some vantage point. We've been working with multiple different industries, not just healthcare in the past. We've done retail, education, travel, like a bunch of these industries. Work pressures, the margin pressures that the healthcare industry in the US faces, and I'm speaking at this from like a neutral standpoint, is incredible. I haven't seen anything like it in any other industry. Dr. Dragutsky works 12-hour work days, goes back home, calls up his patients for another hour and a half. I don't think like it's an incredibly difficult job to keep on doing this with reducing margins. Somebody has to embrace and take this up, make sure that because it takes time to codify and build healthcare safe agents. It needs every single forward-looking physician leader to come in and say, you need equal partnership here. It's not technology companies who are going to build this. It's not physician leaders or practice. It needs Dr. Laparthi's, Dr. Dragutskys, Christa's everywhere in small pockets. It needs many hundred MSs, NextServices to be able to solve this. but that time for leadership is now. It's everything's aligned, but just asking as many leaders to just start partnering on this as quickly as possible.
Excellent. We'll go to Christa.
Yeah, I mean, he's right. The leader, it starts with the leaders, and I think people have to view this as this is not a technology adoption. This is really thinking about a full-on operational change, cultural change to an organization. You have to be open-minded and understand there's going to be a lot of bumps along the way. This is new, right? And you're going to face resistance in every corner. My advice is obviously aligning the partnership, the teams, the understanding. It's not just even about reassurance. It's even allowing our employees to understand they will have a role. It just might look very different. I think all of those things come together will allow something like this to be successful, but we can't let fear, be the reason and the barrier that you don't move forward, because as you guys have all mentioned, this is coming whether we like it or not. So I'd rather be on the forefront and not left behind, because ultimately it's just so much harder to maneuver, if you wait too long. And so that would just kind of be my advice on that, is ensuring you have the right team that you're working with, specifically even with you guys, just having a collaborative partner where we all have the same mindset and goal. I think ultimately that makes for a very good partnership for this to be successful.
Mm-hmm. Satish?
So I want to add maybe another slightly different. So, I think it starts with, let's not think about AI as software. Okay, it's not software. It's not a tool. It's almost like a mirror to human intelligence and capabilities and abilities, and a portion of it, not entirely. We're not yet replacing the entire human. That may happen, but it's important to think of AI that way. And then in the context of healthcare is not really one big, large inefficiency. It's like death by 1,000 handoffs, right? We've seen that. There's like even with designing one agent, as I think it said, 45,000 different lines and iterations and combinations like that. And let's imagine that we've been used to sort of like the whole MBA speak of cheaper, better, faster. What we really need to look at AI, similar to what we look at humans, is like, AI has the capabilities of not just making things faster, but within the workflow of, sort of clinical care and healthcare, it has the ability to delete entire steps entirely. You really are going to remove a lot of these bottlenecks, inefficiencies, and steps completely. You can leapfrog a sort of lot of the stuff. And that adds back to the leadership thing that Christa and Aniket have sort of both talked about, and connect to what I sort of said earlier. Leaders have to look at it as a rebirth, and and I think of an example like an orchestra. It's like, you've got an orchestra, you've got a conductor, and there's all these contributors to the orchestra, and everybody's in sync and knows how to play their instrument and whatnot. AI can do that for you, and you have to think, and a leader has to think of this like, I have an orchestrator in my hand, and I can just I can create an whole ensemble and an orchestra and make it sound like perfect music if I know what to do with it and how. And that's what I really feel that, what my takeaway would be is like, just look at AI a little differently. Our default mechanism is to look at it as a tool, as a piece of software. Let's not see it that way. Let's reimagine the world where it's not just that. It's like a mirror to a human, and then our abilities and capabilities and intelligence.
Mm-hmm.
And Mike.
Yeah, and to continue that stream, it's really a partnership with AI. I think we need to be partners as AI develops, grows. Hopefully, they'll invite us to their coffee, get together and teach us their language one of these days. But we really have to be actively engaged with the process, with the development. And as AI and human beings together, forge the future of the human race. So, and last I want to say is that I appreciate the opportunity that Praveen, Satish, and Aniket has given Christa and I to share our views, because this is not a proprietary one GI thing. This is important for the entire GI community, the entire medical community. So it's great that we get to offer our small views on the future of GI.
Thank you, all of you, for sharing your views and so candidly and so openly, and what you thought and what you're thinking and where everything is going to go. My 2 cents to people listening, watching is, I want to leave you with 2 words, which is take action. If you don't, I'll be very direct and clear about this. You will regret it for sure, especially if you're a clinician. It's not easy to be a doctor. Like some of the most brilliant people on the planet of physicians, like it takes time to be a doctor, and this is the new wave, like, so you should definitely not get left behind. And if anything, this conversation is a direct reflection of how practical and real this stuff is. It's not the future is like really right now. So thank you, everyone. Satish, Christa, Mike, Aniket. This was a fantastic conversation, and we're doing this recording on a Sunday, so I really appreciate all of you making the time to do this. And we'll see you again. Thank you.
Thank you.
Likewise. Thank you, everyone.
Thank you. Take care.